Big reports produced in Washington tend to share a similar fate. They're released with great fanfare, then quickly fade from view, mostly unread and gathering dust in some bureaucrat's drawer. To Err is Human was the exception to this rule. Released 20 years ago this month, the report was a statistical grenade, prompting changes to our healthcare system that benefit patients today. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer for AHA. Perhaps the chief attention grabber in To Err is Human was its conclusion that thousands of Americans died each year under care because of preventable medical errors. The report caught the attention of the public, the media, policymakers, and prompted a top-to-bottom review of standard operating procedures among hospitals, health systems, nurses, and other care providers. Why did this report have such an impact, and how has it improved the care patients receive today? Nancy Foster, Vice President for Quality and Patient Safety for AHA, explores these questions with Mary Wakefield, now a visiting distinguished professor in the practice of healthcare at Georgetown University School of Nursing and Health Studies. In 1999, the year of the report's release, Wakefield was a member of the committee that wrote it. Let's join in their discussion.
Mary, thank you so much for joining us today for this conversation around To Err is Human and its 20th anniversary. As you know, 20 years ago, the Institute of Medicine shocked the nation with its findings in the report To Err is Human and set off what I thought of as really an unprecedented series of activities, studies, events, and other actions aimed at making care safer. Not many IOM reports have, before or since that time, have had anything like the impact of To Err is Human. And you were on the committee that wrote that report. At the time, did the committee have any idea that its report would have such an extraordinary impact?
Yeah, great question. I think that at the time, everyone on the committee knew really very well how critically important it was to focus attention on reducing medical errors and improving safety. And we knew that there was substantial work, not minor modifications, by the way, but really deep substantive work that needed to be done to address safety issues. And I think the committee's intent clearly was to lift up that visibility of what was viewed as really widespread problems around patient safety, and then to recast that approach to addressing them. But I have to say, I don't personally recall anyone focusing on the substance of the report and forecasting what were almost tectonic shifts that occurred in response to the report's release. We knew the report's content and its recommendations were important, and certainly that they would garner attention. But the fact that that report resonated the way it did, not just in the United States, by the way, but in other countries as well, for the committee members, I think that was gratifying because of how important we felt the area of focus was. But honestly, I don't think anyone expected that level of intense interest and rapid engagement around the issues that were raised in the report.
Could you say a little bit more about what surprised you most about the reaction?
I would think there probably were two things that surprised me most. First, the actual report To Err is Human, and then its a second report that accompanied it, Crossing the Quality Chasm. Together, they really provided just a treasure trove of key information and data and recommended shifts in how to approach improvements in achieving the delivery of safe and high-quality care. But, to a great extent, what was interesting, I think, is that the hook for media outlets and policymakers and others, and that hook that surprised me, wasn't everything I just mentioned, but it was, you could really distill it down to one key point that was in the To Err is Human report. And that key point was the estimate that between 44,000 and 98,000 Americans were dying every year as a result of medical errors. That was the one blockbuster statement in the 270-page report that captured the attention of so many different stakeholders. even though, as I mentioned, from my vantage point as a nurse, there were so many key observations. For example, viewing errors in the context of systems design. And even though the To Err is Human report made a really hard pivot from current practices at that time to recommending new, fresh approaches and fresh ideas about how to create safe environments for patients, in spite of all of that information, rich information that was embedded in that report, the real data point about mortality that resulted from medical errors for, I think, a lot of different stakeholders starkly underscored the challenges, and it brought the issues around patient safety into very sharp focus, and then subsequently catalyzed a lot of the conversation that played out in the public arena. So, as I mentioned, a lot of really important content in the report, but surprising to me that there was so much attention around that one data point. And so that was the first surprise. And I would say the second surprise to me was how quickly the United States Congress jumped on the report and its findings. Many years ago, I worked on Capitol Hill for over 8 years, so I have a sense of how speedy the Congress might be in moving to hearings and then legislative action. But what happened after that report was that within 2 weeks of the report's release, I was up on Capitol Hill testifying on the report on behalf of the committee itself. And at that same congressional hearing, there were other key health and consumer organizations, including representatives from the American Hospital Association, the American Medical Association, and others who were invited to testify, again at that very same hearing, about the IOM committee's report, its findings, and its recommendations. And I have to say, back then, and even today, 2 weeks from information about an issue to finding yourself in a hearing, that time frame was lightning fast in terms of congressional action. So that was a surprise as well. And why that, I think, is relevant, that short timeline is relevant, is because that speed at the time indicated the depth of interest in the topic, and it indicated the sense of urgency and concern about the issues that were actually raised in the To Err is Human report.
You're so right. It was remarkable speed for Congress to get engaged on the issue, and for the whole nation to wake up to the importance of solving for safety. In the 20 years that have ensued, many of us in healthcare perceive that safety has gotten better, and even though we acknowledge that more progress still needs to be made. Tell me a little bit about what you see as the most important change to improve the safe delivery of care in the past 20 years, and why you think it's so important.
Well, there have been, of course, a slew of different changes that have occurred in response, I think, and largely driven by that report. Probably the one most important change in healthcare, though, is the level of transparency. And that's the level of transparency about safety, the safety of care that's delivered. If you just think back to 1999 and before that, there was really little that anybody knew about the extent to which care that was delivered in hospitals or clinics or nursing homes. There was very little that anyone knew about the safety of that care. And that lack of information existed for patients that were admitted to hospitals, for example. There wasn't information or a view into patient safety broadly for nurses who were working in healthcare systems or physicians. There wasn't a view into data for hospital boards or even hospital CEOs consistently. They may have known, a nurse may have known, a doctor may have known, a hospital CEO may have known of a particular case, of course, where a patient's safety had been seriously compromised. But often, I think that was pretty much the extent of it. And before 1999, even when you did see some systematic information that was being collected by hospitals or a healthcare system, it was very closely guarded. And as I mentioned, even having that kind of information was uncommon. And when it was there, it was kept pretty almost in lockdown. When I was practicing as a nurse, long before the IOM committee report was released, you really did sort of speak of adverse events that occurred in hospitals at least where I was practicing, in whispered tones. I'm not suggesting that orientation has entirely vanished, but there has been a significant change. In contrast, today, I think there's been a lot of capacity built out and a new orientation toward capturing and analyzing and then using data and being very transparent about that data, really using it to drive performance improvement and to make care safer. And it's turned out that data is a really important motivator for improvement. So I think transparency, having measures that often are far from perfect, but they're just really important to help inform and drive safety has been a major sea change, and that's a piece of developing transparency. And another piece of developing transparency I've sort of alluded to, I think, is that transparency for the public and for providers about how well organizations and institutions are actually doing on certain safety indicators. So clearly, as you indicated, we still have a lot more work to be done, but I think we can celebrate some significant progress that's been made, and transparency has been a big driver of that.
Well, thank you for referring to both the transparency to the individual patient and his or her family members as we talk about errors. I know many of our hospitals have really put in place extraordinary processes to help practitioners know how to have those tough conversations with patients and families about an error that has happened that has affected their health. And then the data you referred to has been a real source of information, both for the public and for those who work hard inside of hospitals and other healthcare organizations to help guide them in making care safer and better. So very important changes that you've referred to. Right now, can I change the conversation just a little bit or focus it a little bit? You've had such an extraordinary career, and among its many parts, you've had the opportunity to focus on the importance of sustaining and improving care in rural America. Would you share with us your perspective on the unique safety improvement challenges or opportunities that exist for those serving rural communities?
Well, there certainly are some important distinctions between the infrastructure and some of the processes, et cetera, at play in rural versus urban healthcare systems, and in terms of important distinctions, of course, too, between rural and urban communities. And I think there are a few challenges that probably come to mind thinking about those safety improvement challenges specific to rural communities. One challenge, I think, is when a patient present with health problems that you don't see very often. In other words, a low-volume condition, so that you have the presentation of an infrequent but complex healthcare problem, and that's coupled with interventions that might carry higher risk. Well, that combination of a condition that you don't see very frequently and the need for complicated interventions to address that healthcare problem, when you've got that combination, that can certainly trigger more opportunity for error. So that's a challenge. But on the other side of that, there are ways to mitigate against those circumstances with training, now with access to subspecialists via telehealth, now with access through remote monitoring and so on. And so that's one challenge, but there's also something unique about that challenge. On the flip side of it is an opportunity that is unique to rural clinicians and populations, and that is that while you might have a low-volume condition that requires some fairly complex intervention, often the rural clinician knows that patient quite well, and they know that patient's history in a way that allows that individual provider the opportunity really to step into the care process differently, because they have that more comprehensive knowledge often about their neighbor or their friend or the person that they see at high school basketball games. And I'd also say that an opportunity around providing care that is sometimes more unique to rural hospitals is because they're quite nimble. They can turn on a dime in instituting some effective strategies to further protect patients from avoidable adverse events. So I think that's one a challenge, but it has some mirror opportunities. A second challenge is a statutory framework that wraps itself around some rural health institutions. So we have a lot of rural facilities like critical access hospitals and rural health clinics that that were designed very specifically with some statutory protections that the design of which was to ensure that those critical access hospitals and those rural health clinics could and would continue. That is, that communities would have access to that type of care that they provided locally. And so there were specific designations that Congress deployed that wasn't so much designed to protect quality or safety, but rather was very much designed to help ensure access and help ensure that healthcare facilities would stay open in small communities. But when those designations were developed, as it turns out, well, they were really important to help preserve access. They weren't necessarily designed to advance or support a lot of the new efforts and opportunities that are currently underway, really to improve safety and care quality through the efforts that we see today around healthcare delivery redesign. And so as a result, I think the pathways aren't always very clear for rural healthcare providers, for rural hospital administrators, and others who are operating in those and other organizations, healthcare organizations. Pathways aren't always very clear about how to, within those, that legal framework, to drive and catalyze new directions in terms of delivery of safe and high quality care. But having said that, you certainly do see, for example, critical access hospitals advancing patient safety and care quality through voluntary efforts. So stepping up to collect and voluntarily report data, for example, around safety and quality. As a matter of fact, it's sort of interesting. As of earlier in 2019, around May, we had well over 1,300 critical access hospitals that had signed an MOU demonstrating their commitment to the Medicare Beneficiary Quality Improvement Project, the MBQIP. And a lot of them, of course, are reporting on really important issues like antibiotic stewardship. They're volunteering to report around influenza vaccination across their healthcare personnel in critical access hospitals. So the point is, rural hospitals are stepping up. They're taking advantage of learning opportunities. They're voluntarily reporting. But interestingly, the original design and protections that were wrapped around some of our rural facilities really were targeted more toward improving access and preserving access rather than safety and quality. And so I think it's timely for us to step back and think about how we can even further support these facilities to do more of what they're already doing, and that is leaning in to get training, to participating and focusing on building sustained cultures of quality and safety, for example, and doing a lot of that work voluntarily. But there's more, I think, that needs to be done to provide them support in advancing that quality safety agenda.
So important that we do provide that support. I know many critical access hospitals and small rural hospitals joined the AHA's Hospital Improvement and Innovation Network and other such HINs that were out in the community because they are so committed to improving the care they provide. So you're exactly right, and I really appreciate the fact that you've highlighted that for us, and the fact that rural hospitals have such a unique and strong opportunity to provide safer care because they do know those in their community so well. So thank you for highlighting those. Could you say a word too, because rural communities do make greater use of nurse practitioners and non-physician providers than many other communities. Is there any special opportunity there that you see for safe care delivery with those professionals?
Well, you're right. In a lot of rural communities, you see a complement of nurse practitioners, physician assistants, other providers, physicians as well. And taken together in a lot of rural communities, that provides that there's the opportunity to see care delivered, especially primary care, that meets a lot of the needs that rural populations present with. Not all the needs in all circumstances, but a lot of them because of that complement of providers available. And as a matter of fact, when you think about nurse practitioners in particular, you can see their importance because they account for right around 19 or so % of that rural primary care workforce. So, yeah, they are a key provider of care, and that's rural primary care and other services as well, services like emergency care. PAs and others, as I mentioned, are also key elements in the rural healthcare workforce infrastructure. And I think, to your question, probably a particular opportunity for that complement of providers is that NPs, PAs, and others are really key players on interdisciplinary teams. And they add significant value, particularly when we see rural teams that are well designed and really fully leveraged to take advantage of the assets of those providers, take advantage of the knowledge and skill of those clinicians, and leverage those assets. If you think about nurse practitioners, for example, they can shift into leading teams. They can participate as a team member depending on the needs of the patient, and frankly, even depending on the needs of the community. But I think that it's important to note that fully flexing that care provider is also sometimes hampered by laws that still remain on the books in some places and that limit scope of practice, even when many, many states and the federal government, too, have introduced more capacity to fully deploy those providers commensurate with their skill set. I think that really what's different today than was the case before the To Err Human report, different today than was the case 20 years ago, is that nurse practitioners and others are able to leverage electronic health records in rural hospitals. Back then, 20 years ago, something like that was probably as scarce as hen's teeth. But now across rural hospitals and clinics, that infrastructure of electronic health records is almost universal. And why that's important in terms of opportunities for nurse practitioners and others really to deliver safe care is because those electronic health records support these providers. They're embedded with evidence-based guidelines, patient self-management tools, safety prompts and reminders, for example. All of those features of electronic health records are important for all providers, physicians too, for example, but they're really important for nurse practitioners and other providers. So again, in rural communities, nearly all hospitals and most primary care clinicians are using them. They have access to them, and that provides a very different capacity and the potential for a safer capacity. It's true, and I'll admit there are some poor functioning and high-cost electronic health records. So there are challenges associated with their use in some cases. But on the whole, they really offer value for driving towards safe care, driving high-quality care that can be delivered and is being delivered by nurse practitioners and others in rural and frankly, for that matter, in urban communities as well.
You're right. Electronic health records have been such an important backbone to advancing quality and safety all across the country. And as we look around the country, we see one of the priorities for communities large and small is this quest to improve care coordination. In our rural communities, care coordination may be an even greater priority for some of the reasons you've already alluded to. As you think about the use of telemedicine and the transfer of patients to a large hospital for certain services and other care delivery strategies that are more commonly used in rural communities, have you seen any particularly promising strategies that you'd like to highlight here as improving safety?
There's some really exciting deployment of resources and reconfigurations that are largely built off of telehealth and telemedicine technology that I think are so exciting. That introduction of telemedicine technology, not a panacea in all circumstances, but without a doubt, that technology provides an abundance of pathways to support the provision of safe care, including, and you mentioned it, assisting in care coordination. And what we're seeing for rural communities is that it's continuing to garner significant attention and more support and more utilization in the delivery, for example, of everything from telebehavioral health services to tele-ED services to increased utilization of remote pharmacy resources. And all of those applications, I think, deploying that technology are really helping to improve both access to those services, but also the delivery of safe care. And I think that that's been an absolute sea change in terms of connecting and coordinating and building out partnerships between different healthcare delivery systems that might be connected now between rural and rural communities and healthcare facilities and rural and urban healthcare facilities. It's allowed health to be deployed and health services to be deployed really differently. And I think that partnership that's now occurring in terms of connecting different facets of healthcare delivery systems through that technology is really benefiting the communities. It's helping patients to stay local, and it's helping to provide a backstop and assist in ensuring the delivery of safe, high-quality care. So major changes that look very different today, and from my vantage point, are really exciting in connecting the coordination of care between facilities, again, rural to rural communities, rural to urban communities, making services available locally in rural communities that once you might only be able to access by driving 95 or 100 miles to get access to care. And as we all know, and especially in urgent situations, that time can make a big difference. And transportation, not always easy for rural family members and rural patients, and so sometimes care would be avoided and could be avoided completely. So this has really provided an opportunity for continuity and care coordination and the delivery of services right in rural communities that helps to support the care that's actually already there on the front lines when that additional support is needed and delivered in a safe, coordinated fashion.
That's great. Let me ask about something you alluded to a moment ago, and that is our rural hospitals are working very hard to provide safe, high-quality care. I'm proud to talk to their community about what they're doing, both how they currently are performing and what they're doing to improve. But they run into big problems trying to use some of the standard measures that exist because of the volume issue you alluded to a little while ago. What do you see as that biggest challenge in characterizing patient safety in low-volume settings? And what do you think the public should expect hospitals to do to best share information with them in order to inform them about how safe and high quality they are?
I think that in terms of the biggest challenge, you pretty much hit the nail on the head, at least from my vantage point. When we think about patient safety in low-volume settings and the challenges that providers and others face, rural healthcare facilities really need highly, highly relevant safety measures. The great news is that there's work underway on that front, but that work is critically important. It's not enough to generalize safety measures, all safety measures from urban to rural healthcare infrastructure, because the circumstances frequently are quite different. So bottom line, rural health facilities and providers need highly relevant safety measures. The National Quality Forum has had a rural work group that's looking at rural relevant measures development. Rural hospitals, including critical access hospitals, are willing to report, of course, and they're doing it voluntarily. But fundamentally, it's a challenge when you don't have a robust, relevant set of measures. And it is the case that when healthcare executives and providers in rural communities see data that points to problems with patient safety, they're absolutely committed to addressing that. But that pivots from meaningful measures and helpful and useful data displays, and it pivots from having strategies that can really drive performance improvement. So I think that's, you said it, it is having those highly relevant measures. And the good news is that work continues to push forward. You also mentioned, well, what should the public expect small hospitals to be doing in this space? I think that a lot of rural communities should expect that their health system is connecting with and coordinating with other facilities to, when they need it, access expertise and technology that might not be available locally. I think that the public should expect hospitals to really be functioning as learning improvement, continuous learning organizations, and focusing on improving performance really across all employees in the facility. That is that whether they're rural or urban hospitals, that they're using data, that they're using information with an eye toward constant improvement. And that's important in rural facilities just as it's important in urban facilities. It's important to the communities to be able to know that there is always an ongoing effort to drive toward ever safer care and higher quality care too.
Our participants have been Nancy Foster, Vice President for Quality and Patient Safety Policy for AHA, and Mary Wakefield, Visiting Healthcare Professor at Georgetown University School of Nursing and Health Studies, and a member of the committee that wrote and released To Err is Human 2 decades ago. This is Advancing Health, a podcast from the American Hospital Association. Thanks for listening.